Aloha everyone, it is Ajanette and I am here to present your final lecture on death and dying. And although this can be a somewhat sad and depressing topic for some of us, particularly if you've recently lost a loved one, it can also offer some peace, some insight, and maybe some permission to continue on in your life while still holding space and love in your heart for the person lost. So let's dive in. When we talk about death and dying, death is not always straightforward, right? Sometimes there is something known as what we call brain death. So we have to kind of define death. And we know that, death occurs when our heart stops and we have no more bodily functions. Everything has ceased, all functions. And that death is pretty clear cut. But the other death, the death when we have still some activity, bodily activity, but our brain is not functioning properly and our body is relying on machines. That is a different type of death, right? And sometimes medical professionals need to determine whether or not the damage is irreversible, whether or not you are capable of living without the machines, and the timing by which people may want to remove that additional support and function. And sometimes that can be very emotionally distressing. It's most definitely distressing to talk about when you have a loved one in that situation. So I think it's better to have those conversations now. What are your wishes? Do you want to live on machines? And particularly for someone like me that is post-cancer, I'm in middle adulthood, I've had these conversations very openly with my children, and it offers them some peace and some direction, so they're not left having to make those decisions for me, and additionally, so they're not left in disagreement with one another, right? Because they may not be able to come to an agreement easily. So me offering them that clarity of my intention and my wishes is definitely something that's a gift to them, whether they recognize that or not. So let's talk about, what is the process of dying and what do people often experience? If you've ever had the true privilege of being with someone at the end of their life, and it is a privilege, when we support a loved one and engage in that end-of-life caretaking, it is a gift. We can cherish those final moments. And there's a lot that happens both physically, emotionally, spiritually as well. And so being able to be part of that transformation can be such a privilege. But what you see is you see a declining appetite, you see increasing sleep levels, increasing weakness, increasing inability to control their bladder and their bowels. They may become a little disoriented and even restless, a little impatient, and they just need more care. And then as the day comes closer, you might see them less and less awake. So when you come to visit, or if you're doing the caretaking, they may spend more and more time sleeping. You may see them occasionally pause in their breathing. You often might think, oh my gosh, they've passed, and they haven't. So longer durations might pass. Their blood pressure can sometimes slow and their heart rate slows, so it makes you think that they've passed, but they haven't. Their body is producing less urine. It might become darker because their organs may not be functioning as effectively. They might even be murmuring to others that you can't see, that they might be having visions themselves. Some people who have had near-death experiences describe seeing loved ones that have already passed. So you might see them, reaching in the air, maybe picking at covers, Sometimes irritation, sometimes discomfort, sometimes picking at things that you don't see. And then right before they pass, you almost see them become comatose. And sometimes you think, well, I was just talking to them yesterday, but they've kind of slipped away and their body is just catching up with them. So the breathing might not just become more shallow and have longer pauses, but you might also hear a grumbling in their breathing, and their pulse might be hard to detect, very weak. They might feel very cold to touch, even maybe appear a little bluish, and that rumbling in their chest as they're breathing can be a little disconcerting. It can be uncomfortable and awkward, but it's just the body's way of shutting down. So again, it's it is a sad time, but a privilege to be able to support them as they pass, to offer that love, that encouragement, and sometimes that permission that it's okay, that they don't need to stay behind, that we're going to be okay, that we're going to take care of their loved ones. So when we think about death, we really think about what's happening physically, and we rarely think about what happens socially. Sadly, though, we don't always treat individuals that are nearing death or at the end of life with a lot of compassion. We talked about this a little bit in the late adulthood chapter, but sometimes in aging individuals or individuals struggling with health issues experience a social death where people kind of ignore them. They don't engage them. They stop talking to them and including them and visiting them. They stop consulting them and letting them to be part of the decisions. And unfortunately, that sometimes means forcing them to do things that they don't want to do, or forcing them in circumstances they don't want to be in. And it can take away their emotional motivation and their psychological health and functioning and focus. And so when we impose on the elderly in this way, know that we're creating a social death, and we might actually be expediting the time to their physical death. Social connection, social networks, and that engagement is a protective factor, and it offers a richness, a support, and a protective barrier for us really at all stages of life. So do keep that in mind as you have aging loved ones. Now, when we look at how people die, we often think of like a chronic disease, but it can also be a sudden or acute onset of some heart incident or some cancer. Sometimes when you're diagnosed, the time to death can be very quick. Sometimes respiratory diseases can be long and laborious deaths. So people are in a chronic state of declining health, and it could in fact be an ongoing state of dependence or an increasing state of dependence. So this lists out the most common causes of death, and then note that changes by age. So at very young ages, death is often due to maybe birth defects or premature birth where they have an extremely low birth weight, or their lungs haven't matured and other complications. But it could be also related to pregnancy challenges, sudden infant death syndrome, where an infant dies before the age of 1 unexpectedly with no explained cause, or an unintentional injury. The injury note continues to be a theme throughout really our early adulthood. But then, sadly, we do see now inflicted deaths, right? where homicide becomes a leading cause of death. It ranks differently, but at different stages of life, it still becomes a risk and problematic. You do see young children who might have some childhood cancer diseases, or even some heart diseases, heart defects, valves aren't functioning, things of that nature. Childhood cancers continue to be a primary cause of death through those teen years, reduces down to 4 into early childhood, and then that risk increases when we enter middle adulthood and late adulthood and on. And then chronic lower respiratory diseases, and you'll see that also becomes a common cause of death in middle adulthood as well. Suicide and taking your own life now in these preteen years becomes a risk that we need to consider, and it continues to be a factor, third leading cause of death for our traditional college age students, second leading cause of death in early adulthood, and the fourth leading cause and fifth leading cause from early into middle adulthood. And then you start to see heart disease become more common now throughout early adulthood into middle adulthood. Now this is in the US, right? Heart disease is not as much of a risk factor in some countries. A lot of this has to do with our diet and our sedentary lifestyle. So the more you can do to have a healthy, balanced diet and to engage in an active life, the better, right? So when you're talking about throughout the world, we differentiate between developed and developing countries, which are also differentiated based on wealth, where developed countries have greater wealth, greater GDP, greater infrastructure in place. And so in those countries, we typically have a longer life expectancy and people live well into late adulthood. In developing countries, though, about 40% of deaths occur to people under 15. And so just under half of the population never reaches adulthood. 30% die from infectious diseases that are fully preventable and treatable in developed countries. And then additionally, birth, because it becomes a common source of death, lack of breathing, birth trauma, and then infancy and toddlerhood, often related to malnutrition. So important to note that the type of society that you live in, the country in which you are born, purely potentially by accident, right, by fate, actually dictates what your risks are and how soon and the type of life expectancy that you have. So people die in different places, not just at different times and from different causes, but in different places. In the US, we typically rely a lot on hospitals to care for our loved ones in times of need and crisis, and even when they're passing away, hospitals in the US have been a primary choice. But historically, or in other countries, that's not the case. People take comfort in dying in their home. Of course, when they have a chronic illness that cannot be treated, right? So we understand the need for hospitals to take care of us when we're sick or when there's an urgent circumstance. But when we're talking about understanding that death is imminent and in process, it really varies from family to family, country to country, culture to culture. So being mindful that in developed countries, we often rely on hospitals, but in other countries, not so much. And so recognize that people might have different views on that, right? We also kind of change our understanding of death throughout the lifespan In infancy, they don't really understand death, right? They understand mom or dad isn't around, grandma and grandpa aren't around, but they don't understand that they've passed. Early childhood, they can start to understand death, but not in a realistic way. It's kind of more of an abstract concept to them that they don't wrap their brain around fully. They certainly don't always understand death is permanent. So you can tell them someone has passed away, and then they might ask for them an hour later, right? In early, middle, and late childhood, they actually might blame themselves a little bit, think that they did something to cause it, and carry some guilt. In late childhood, because they understand the finality of death, they might start to fear it because they start to understand the risks of death, and they understand maybe some health issues that parents might have or grandparents might have. They actually might be afraid of losing their loved ones through death. In adolescence, now we learned in Piaget's theory that they start to have formal operational thinking, which allows them to fully understand abstract thoughts. They become scientific thinkers, but they start to ponder death. They think about death in a very different way. They think about the afterlife in a different way. Now, remember, they have that adolescent egocentrism, which includes the imaginary audience and the personal fable. So they might not think that they are risk. Remember, they're special. It's not going to happen to me. So they still engage in risky behavior, not understanding the potential or imminence of death quite often. And then in early adulthood, we're in the point in our lives where we're building our lives. We're getting married. We're starting families. We're starting careers. We're entering relationships and building partnerships with people and that we're moving in together with, maybe. And so we don't think a lot about death as much, and we don't fear death as much. But those fears and realizations start to really sink in middle adulthood. And we do start to worry, particularly when we still have children. We worry about providing for our families, leaving our families behind. How are they going to be taken care of, right? And then in late adulthood, we may not be driven as much about fear of death, but we may think about how we're going to die. We may be more afraid about how we're going to die. And we may actively be thinking about planning. I think planning should start early. As soon as you become an adult, you should start. But I'm also a former financial advisor, right? I have 20 plus years in financial services. I did financial planning actively. And so I do want you to think about, if you're over the age of 18, mapping things out, right? Not in a fear-based way, but just because you never know. And so it's better to be prepared than not prepared. Now, when someone does in fact have a terminal condition such as cancer, they have the opportunity to receive different types of care. So curative care, it's focused on curing an individual, fixing, treating, taking care of a disease, removing some sort of tumor or illness. So the focus is on curing. The other types of care we're going to talk about, the focus can shift from trying to fix or treat or eradicate an illness to now, let's look at how we can offer you comfort. Let's look at how we can manage your pain. Let's look at how we can preserve your quality of life and your dignity as best as possible. That's palliative care. You have a terminal illness, and there are treatments and interventions. My brother had a surgery, a brain surgery. He was diagnosed with a rare kidney cancer, and he had a brain surgery because the tumor in his brain was disrupting his quality of life and causing immense distress. And so they did a surgery to remove the tumor, not with the expectation that he would be cured and live a full life, but with the desire just to offer him some relief and comfort. That was palliative care. Then we have family caregiving, where about a third of our population are caring for loved ones. I watched my son-in-law do this with his Nana. It was one of the most precious and endearing things to watch his love for his Nana and the comfort that she took in him while he was caring for her. And that's rare. Quite often women are the caregivers. But to see this young man treat his Nana with such love and grace and support was truly so admirable. And she didn't want anyone else caring for her but her precious Kyle. She loved and adored him. And that was also quite a special thing to see. So when I say it's a privilege, it really is. He will cherish those memories forever, for the rest of his life. And he very much soaked in every opportunity and every moment he had with his Nana. Now, sometimes caring for your loved one in the home is not always possible, and they need to go on to hospice care. Hospice care means that professionals now come in and take over those responsibilities. Sometimes it can be in your home, or they can be in a hospice facility. And so that really is up to the family, it's up to the patient, and sometimes it's up to the insurance provider. Quite often you have additional benefits once you go on hospice that weren't readily available through regular health care. Doesn't that suck, right? That we are offered more care and more benefits and more options when our loved one is dying. So hospice is available for people who have a terminal illness and they have a projected life expectancy of 6 months or less. Often that's associated with cancer. Now, they don't always live those full 6 months, and sometimes people can be on hospice for years and years. The median or middle time that people are on hospice is 18 days. I watched my brother-in-law just last year. He was diagnosed and he passed away within 2 weeks of his diagnosis. And I have an auntie who fights and fights. I have an uncle who fights and fights, and they've been able to endure cancer for extended periods of time now. And so we applaud those in whatever stage of the battle that they're in, and we hope that they get the care and support that they need. Ultimately, both palliative and hospice care are really about offering comfort to the patient, doing their best to address their pain and reduce their stress levels, and support them not just physically but emotionally and socially. So hospice treats not just the patient but the entire family. They are there to be a resource, an educational source for the entire family. And so it involves often a team of doctors, nurses, medical assistants, social workers, sometimes pastors, or any kind of spiritual advisors. They're there at different times of the day, sometimes day and night, depending upon the condition. But they absolutely provide comprehensive care. And I see them quite often supporting families in the grieving process, attending funerals, and continuing to be a resource and support long after the loved one has passed. So, as I mentioned, I think every individual who's 18 years of age or older should engage in end-of-life planning. That includes creating, a plan in advance, including legal directives, legal documents. So when we talk about advanced care planning or end-of-life planning, we're talking about putting the legal documents in place that are necessary to take care of you. An advanced directive helps to take care of your healthcare needs, allows you to dictate, do you want life support, don't you want life support? So it allows you, should you become incapacitated, to still have a say in your healthcare and what you want. And it allows you to lift that burden from your loved ones. You can create a living will that actually you can do it by video as well, and have that supplemental resource that helps to explain your healthcare initiatives, whom you want to be making decisions for you. Sometimes it's not always the same person making financial decisions. You want someone that has a strength, a resilience, and objectivity, who can honor your wishes even if it disagrees with their own. So if you don't want life support, if you want a DNR and you don't want life-saving measures taken, that person needs to be able to honor that, because once you give them authority, they can actually override your instructions and your wishes. So who you name as your healthcare power of attorney is so, so important. You also can do medical orders often by, directly with a hospital or your doctor. They have documents that you can sign as well. And so you have, again, that decision making. In addition to your healthcare needs, you need to think about what are your financial needs. So a financial power of attorney gives someone the authority to continue to manage your finances, including paying your health insurance, including paying your long-term care insurance premium, your mortgage, things of that nature, so you don't experience additional financial crisis that is then passed on to your heirs. So in the event that you're no longer capable of making decisions for yourself or you're incapacitated, the financial power of attorney takes effect while you're living that gives someone that authority to make those decisions. They should be intelligent, and they may not be brilliant with everything, but they're at least smart enough to seek advice from a professional. Make sure they have integrity. Make sure they're not in a financial bind themselves where they're tempted to steal from your resources, right? That's important. You can also establish a living trust, which owns assets that are designated to the trust while you're alive and when you pass away. And this is a legal bridge that allows you to pass on assets to an heir or to multiple heirs in a streamlined fashion to avoid probate, which is an additional legal court process they have to go through. It's expensive, it's time-consuming, and it needlessly draws resources and energy from your heirs and from your family and loved ones. A will can be put into place so you can direct where you want things to go in the event that you pass away. But sadly, a will does not avoid probate. So while you should have a will for those things that aren't owned by the trust, you want to make sure that you have a pour-over provision in that will. So whatever is not in the trust now becomes owned by the trust in the event that you pass away. And you want to do that just in case there's something that was missing, or for other assets like personal property that don't have a title and it can't be owned by the trust, or like a car, something of that nature. So whatever is governed by the will is still subject to probate. So you want to minimize what is left in the will and make sure as much of your assets as possible are actually in a living trust. This has tax benefits, important to seek a counsel from a financial advisor. Now, I do want to be mindful that, we're in the U.S. and sometimes we're ethnocentric and we assume the whole world should act like the U.S. and view the world like the U.S. and have the morals of the U.S. and sometimes with death we do that as well. We talk about death. We have a transparent approach quite often, and we engage our loved one in the decision-making process. That patient still has rights till the very end. Well, that's not always the case in other cultures. They may or may not involve the loved one. They may or may not be transparent about the circumstances. They may or may not want to have hospital intervention or not hospital intervention. So do bear in mind that different cultures view death and approach death and these conversations, or lack thereof, differently. And so you do what's right for your family. They may also approach euthanasia differently. So euthanasia is when we intentionally end a life due to some sort of terminal condition or a severe disability that hinders them from maintaining a quality of life. There's two different types of euthanasia: active, where we are intentionally inflicting that death through typically medication, and then passive, I shouldn't say typically, through medication, and then passive euthanasia, where we might just withdraw life-supporting care, like a feeding tube, a respirator, things of that nature. There is physical assisted suicide that is legal in different countries and in different states within the United States. Currently, we have 6 states that allow physical assisted suicide. There's very strict laws in place. You typically have to be at least 18. You have to have a terminal condition diagnosed. You typically have to have 2 or more physicians sign and effectively certify that your condition is terminal. And then you also have to sometimes go through a psychological and psychiatric exam to make sure that you're of sound mind to be making these decisions. So each state has different laws, but that's the general process. And there's definitely opposition. Sometimes from a religious standpoint, they look at it as murder. Sometimes, doctors themselves may feel like it's a violation of their Hippocratic oath, where they swear to care for the well-being of individuals and save lives, not take lives. And then governments and legal scholars really hotly contest and debate this at times. And so it's important to be aware of what your rights are in your respective home. Now, once we passed away, families take comfort in different processes, right? Protocols, traditions, ceremonies. It gives them peace. They draw on their faith. And these ceremonies can offer them a sense of closure. They can offer them comfort. And for some, they feel like they're absolutely critical because they affect the afterlife of their loved one. And so they want to make sure they're honoring these beliefs. You have Hindu having different approaches. They believe in reincarnation, so their loved one will pass on in another form. Judaism, they also go through some ceremonies with the body. They go quickly to burial, and that's important to give their loved one over. And then they also, I recently had a cousin pass, and he is Samoan, and the family comes and visits, and my cousin and the children were, it seemed a lot. It was a lot like Shiva, where the family comes and they bring food, and they gather and they pay their respects, and they share memories, and they actually offer gifts of money to support the funeral. So Judaism and other cultures definitely have that honoring of the family and the loved one through those family visits. Muslims and Catholics as well have really important traditions and practices that they believe are necessary so that their loved one can go on in their afterlife, and so that the family can pay their respects as well. So whether we find comfort in traditions or ceremonies or not, we are often left with a state of grief when we've lost a loved one. Now, grief can be a response to any loss, not just the loss to a loved one, but also death, a relationship, a job, a relationship, a dream. And so we grieve over different losses. When we're talking about bereavement, we're talking about a period of grief, a period of mourning, associated with the loss of a loved one through death. And that bereavement period